Welcome, everyone. It gives me great pleasure to introduce Dr. Arno Schmidt-Trucksäss, who's going to be giving this seminar today. He's a professor of internal medicine, sports and agriculture and exercise medicine, and nutritional medicine, as well as director of the Center for Sports Medicine at the University of Basel. During his career, he has received numerous awards and international recognition for his work. Dr. Schmidt-Trucksäss is an associate editor of the Journal of Atherosclerosis, which has a very high impact factor in our field, as well as a member of several journal executive committees and editorial boards. The major focus of Arno's research relates to healthy aging and the role of physical activity in maintaining muscle and cardiovascular fitness, specifically to slow the development of premature frailty. Likewise, much of his work centers on the role of physical activity in maintaining cardiorespiratory fitness and its relationship to heart metabolic and arterial health. Again, is related to healthy aging. Dr. Schmidt-Trucksäss is committed to establishing exercise as an effective medicine for prevention and treatment of non-communicable chronic diseases in society. And related to that, he has published over 300 articles. In addition to physical activity, he has also made it quite clear that he recognizes that the pillars of lifestyle to support healthy aging also include nutrition and behavior change, which is how we met. He invited me to contribute to a review article on cardiovascular prevention with equal weight given to physical activity, behavior change, and nutrition, which turned out to be very productive and enjoyable. As a reminder to the audience, please add your questions and enter them into the Q&A feature of Zoom as they arise. And with no further ado, I will cede this virtual space to Dr. Schmidt-Trucksäss. Welcome to the HNRCA.
So many thanks, Alice, for this very nice introduction. I choose the most difficult name you can imagine, with Schmidt-Trucksäss. So that is the German pronunciation of that. And but anyhow, and it's unique because Schmidt is nearly 6% of the German population. So yeah, with the Trucksäss, I'm worldwide the only one. So many thanks for that. And I think I have to share first my slides. Or do you see my first slide?
We see it.
Oh, you see it. Okay.
Mm-hmm.
Yes, then I just go into my presentation, and I first want to thank you, Alice, coming over to our meeting, to the arterial stiffness meeting, which we hold in October last year. And it was a fantastic presentation you hold over there, and you contributed with the nutritional part so much to our conference, and it was really, really very, very nice. And once again, thank you coming over. So now going into my presentation, I have a content. I want to go into these 5 topics: the aging society and disease, and then from curation to prevention. Maybe we have to think a little bit different. Then going really quickly into mechanisms of aging, and then healthy aging and aerobic capacity, and exercise and healthy longevity. That's my content. So I want to start with the aging society and disease. And if you see now the life expectancy and the development of life expectancy from the 19th century, then up to 2021, then you can see it's increasing all the time. Only the wars were in between, which reduces the life expectancy, but it's going up and up and up. In Switzerland, you can see over here is one of the states with the oldest inhabitants or the highest life expectancy at average. And if we look into the future, then to 2100, then we can see that we get older and older, and the life expectancy is even growing. And it's not only growing in Switzerland, but in North America as well. So that might cause a problem in our, let's say, in our healthcare system, and it might cause problems if we do not adhere to a certain lifestyle, which I want to explain, which is necessary. And the real topic of that is that that you have to look at healthy life expectancy and the years lived with disability. And if we look here now at data of the United States, and there are data of Switzerland and all other countries as well, but we look at the United States, then you can see if we compare 2011 and 2021, that healthy life expectancy is reducing. It's 66.7 in 2011, and it's 64.4 in 2021. And that is, I think that is a little bit of a disaster. But another disaster is that the years lived with disability should decrease then as well, but it increased by 5 months if we compare to the 2011 to 2021. And I think it should be really going the opposite. We should increase our life expectancy and we should reduce the years lived with disability. And I say this because I had a look at the healthcare expenditure per capita. Here, data from 2021. And you can see that the United States is here at the top, and Switzerland is roughly over here. But we have a look at the United States, and this is and if you look at the scale, then you can see you have the highest investment per capita in healthcare, but the years lived with disability are increasing. So you invest in disability, in carrying disability, instead of avoiding disability. So it should be completely the other way around. The more you invest in health, the healthier you should be, and the higher the life expectancy should be, and the lower should be the time you live with disability. So it's really, at the moment, it's really the opposite. And if we look then at the causes of death, and you can see heart disease is reducing over time. Here is the scale from 2000 and 2018. It's reducing. Cancer is reducing. Nearly all other diseases are reducing. And we do not really know why we die. But the multiple causes of death, they are increasing. So our disease add to disease, and disease add to, the disease accumulates over the years. And if we look then at this data from Luigi Ferrucci from this really seminal workshop where they on geroscience they made, then you can see that if you have one disease, then it's easier to acquire a second disease. From 15%, the probability at the age of 60 to get one disease. And if you already have one, then it's 20%. And you have two diseases, then its probability is 23%. And so it's increasing. And if you are already multi-morbid, then you have the chance of 50% getting the fifth disease. So why does this matter? And if we then look at longevity, then you can see that those who are the supercentenarians, and so this is the line over here, they acquire the first disease very late in their life. So the disease-free survival is for them the highest percentage of all of them. And if you are then in the control and just the average of the population, then you acquire your disease very early on. So it is very important to avoid disease during the whole life course and get it as late as possible in your life course, which is here shown by the supercentenarians who are really easily getting over 100 years. So if we then sum this up, we can say diseases and aging share similar mechanisms. I have to show this in a little bit more detail. And disease drives aging, and aging drives disease. And if we then look a little bit at longevity, then we can say disease-free aging might result in healthy longevity. But this has to be shown in the future. So coming to the next point, from curation to prevention. And for this thinking, we have to lay a little bit the groundwork and have to look at essential considerations, and we have to think a little bit change in the future. And with this thinking, I want to show you a nice publication of Douglas Seals from Boulder, who's a friend of mine. And he took a scheme or a graph of Fried, and I think this is a really nice thinking of that. And if you look at this graph, you see sometimes we are born, and sometimes at some point we die. And morbidity starts at a certain point. And you all know that curation extends your life, but the time of morbidity is increasing as well. And what we want to have is the compression of morbidity. It may happen in a way in some guys, but I think it's not ideal, but it should be in this way that we have a short period of disease at the end of our life. But what we forget in this is the function of the body. And we do not cure let's say, we cure by medicine, but we do not cure by function of the body, by functioning of the body. And in this way, in this publication, aging and the health span is associated with a good function of the organism. So a good muscular function, good endurance capacity, good balance and flexibility. And if we want to increase the health span, so the time we live without disease, then we have to improve our physical function. And if we do this, that is the hypothesis, we can optimize longevity in that way that we really compress aging or morbid aging at the end of our life. And turning this a little bit upside down, I want to explain it a little bit more different, or a little bit different from that. So here's the age, and here's the function of the body. So that is physical fitness. And we have a threshold for disability or frailty. And then we age, and while we age, the function of the body reduces. Yeah, and at some point we are going below the disability threshold. And just the curation, or the normal thinking of curation is in that way that we live longer, but also longer with disability. So the time we live longer, and here the time we live with disability is longer. And it would be ideal if we have a very short period which we have to live with disability at the end of our life. And what we can see in these graphs, that we have to slow the pace of aging. And the pace of aging is here the tangents we have at this graph. And if we slow it, if it's not that steep, yeah, this would be optimal in order to have really optimal health and to have an optimal health span. So slow the pace of aging as a marker of disease accumulation, morbidity, and finally frailty and mortality. And to show this in a little bit different way is that we have the physical fitness over here, and that we have aging over here. And here's the area of disability, the threshold of disability and frailty. And people want to avoid this. They want to avoid disability. They want to live independent. And if you look at the time course, it's in that way that we usually increase our physical fitness, and during adulthood, we reduce it. And at the end, if we are elder, then we go into this area and we are disabled and we may be frail. And we can, if we have a proper lifestyle, then we can reduce the time we live with disability. And if we have the best lifestyle, then we can do it in this way, that we do not reach the disability threshold and that we die without any disability. And I think this span is in a way in our hands. This individual span, we can look at it and we can do something for our physical fitness in order to avoid this frailty phase at the end of our life. And to look a little bit at my perspective, at my personal perspective, I have a dream. And if I get 94 years old, I want to go into my rose garden as a fit man without any disabilities. And then if I have a final look at my rose, I would like to die if it's necessary. And then there may be something stone written in there in memoriam of the old and fit men in the rose garden. That would be what I want to do, what I want to have. And in this way, I want to follow again Douglas Bob Seals in that way that I want to really to promote this, that we use a lifestyle and behavioral and pharmacological strategies together in primary prevention to avoid the reduction of physical function, and in secondary prevention as well, in order to limit disease and limit disability. And I think this thinking is more on the pharmacological side at the moment, or at the point that we make surgery and that we exchange joints or whatever. But I think the lifestyle and behavioral aspect should be more on the forefront. So coming to my next point is the mechanisms of aging. And if we think of the mechanisms of aging, we have to think of these, let's say, of this book, the Geriatric Medicine and Gerontology, and there's written, mechanisms of aging are, in fact, failures of homeostatic mechanism that maintain life with attendant cellular damage and dysfunction driving deficit accumulation that manifests clinically as chronic diseases and a decline of physical and cognitive function. So there's a failure of homeostatic mechanisms, as I want to point it out a little bit more in detail. And we want to maintain life without cellular damage and without dysfunction, yes? And therefore, it's necessary to avoid a decline of physical and cognitive function. We can see this in this way. And I think one of the first who think of this was Rudolf Virchow. Rudolf Virchow, as you can see here, at some point, at some moment in history, there were some really good researchers in Europe, and Germany was one of the German-speaking area was really one of the areas where the Nobel Prizes were. And you can see here in 1858, he wrote about cellular pathology. And he wrote about it, about the physiological and pathological, let's say, knowledge, how the tissues ages. And Rudolf Virchow, he first hold a lesson about the change of the aging tissue. And you can see he was the pioneer of cellular disease. And if you have a look at this, this is the aorta. Yes, it's the aging of the aorta, what he was looking at. And he first described that the elastic lamellae reduces and the collagen increases while aging. And there was a thickening of the intima media and the thickening of the endothelial layer. And this was the first description how the aorta, how a big vessel changes over time, changes with aging. So now it's clear that there are so many mechanisms described, and the hallmarks of aging are really described in this publication of Lopez Otin, and I think that's really he really describes in this publication all the mechanisms which are dysregulated in a way when we age. And that is the telomere attrition, the reducing of the length, that are the epigenetic changes, and the loss of proteostasis, the disabled macroautophagy, so the impossibility for autophagy of diseased cells. We have dysregulated nutrient sensing, which goes into nutrition. We have mitochondrial dysfunction, cellular senescence, the stem cell exhaustion, the altered intercellular communication, chronic inflammation, and the dysbiosis. So many or these mechanisms mainly cause aging and cause as well, and we share this in that way, disease. And then if we look at that in a little more, let's say, complex framework, in the conceptual model about the important factors of physical functioning during aging, then you can see on this side all these hallmarks, all these mechanisms of aging, and the possible intervention. You see pharmaceutical, hormonal, surgery, and nutraceutical. And that are the mechanisms going in this direction. But what we do not see on this as an intervention, we can only see here. It's the intervention by lifestyle, by diet, by exercise. And I think we should really go into this more into this direction, because we can influence by diet and exercise all these different mechanisms. But if we think this as a framework, of course, this is chronic disease and this is aging, and it is combined in these mechanisms. And sometimes we do not know whether we get chronic disease or whether we age. So to disentangle this, I think it's the most difficult task what we have to do in science in the future. So if we want to tackle aging and want to tackle disease, of course, then we have to reduce the sedentary lifestyle. We have to improve sleep. We have to improve the psychosocial factors and environmental stress, and of course, avoid hospitalization and mainly over nutrition, and of course undernutrition as well. So there are behavioral factors and there are biological mechanisms which interact with each other. And there are so many options to make interventions in order to really properly address this development, to avoid increased aging, and to improve longevity, healthy longevity. So coming to the next point, healthy aging and aerobic capacity. And that's now the topic I'm involved in for many, many years. And if we look at that, I want to point out one study which we did in the past years, and that was the Complete Health Project and the Complete Heart Project. What did we do in this project? We had to see that only a very few studies had data on healthy subjects while aging. And that is the Baltimore longitudinal study of aging. And there are other studies, but they only had convenience samples. If they didn't find anything, they said, okay, you are healthy. And that is healthy aging, which is based on that. And we made it the attempt going in another way. We selected these people and we asked them, do you fulfill these inclusion criteria? So they had to be between 20 and 100 years. They had to be non-smoker or long time, an ex-smoker, and they had to have a normal body mass index. Overweight was allowed, but not obesity. And the exclusion criteria were quite strong. They haven't had myocardial infarction, stroke, artery disease, cancer, diabetes, especially renal failure and chronic bronchitis in the past, and no diseases which was a contradiction for maximal exertion, because we want to make exercise testing beside any other mean or several other means what we want to know. And then we compared them with those patients with heart failure. And heart failure patients, we selected 80 subjects with heart failure, and we compared them with those with this rigorous exclusion of disease. And what we did is that we made several analyses on the morphologic part of the vascular part of the echo of the heart, muscular measurements of strength, cardiorespiratory fitness was assessed, neuromuscular function, for example, by balance testing, and metabolic function as well by taking blood and having a look at the blood at metabolic factors. And that were all looked at regarding what did they contribute to fitness. And then we had to look at the behavioral components, and the behavioral components died, of course, make a screening of that. Physical activity was assessed by accelerometry for 14 days. Smoking, alcohol consumption was assessed, and stress management by resilience questionnaires. And all these things were done, assessed together in all these subjects. So the subjects underwent nearly 1 day of examination. And you can see here all the examinations which were done in these subjects. So are the parts of physical activity, for example, strength testing, balance testing here, jump testing, hand grab strength, balance in the way when they went over the floor. And then we make a spiroergometry as well, and physical activity by accelerometry over 14 days. And then there were questionnaires, of course. We are making bioimpedance measurement, and we had looked at the vascular system, especially at the heart, at the echo. We make FMD of the brachial artery, we make pulse width velocity, and we looked at the retinal artery. So in order to assess the small vessel and the function of the small vessels with flicker response. And of course, we took a lot of blood for testing, which is going on at the moment and continuously, because we have many samples frozen in our minus 70 degrees fridge. So what we want to know is, if we come back then to this aging, let's say, scheme, want to know what are the factors which really discriminate those with disease, with heart failure, from those who were healthy during their aging period. And we calculated the health distance, so the distance which derived from all the parameters we measure, which discriminates best between healthy and those with heart failure during the course of aging. So just to say this, we made all these measurements, and we want to see whether the pattern was different between aerobic strength and balance and gait parameters, and here from between those who are healthy and who are heart failure. And of course, all the other parameters which we measured went into this analysis as well. And the result of this was not very astonishing for us, but this was shown for the first time in that way, that it was the parameter discriminating best between health and disease was the exercise capacity measured by spiroergometry. And if we put all the different factors together, it was always cardiorespiratory fitness, which was the most important parameter which discriminates best between health and disease. So what is the power of exercise and fitness to slow aging? What makes the difference between health and disease? What makes the difference between those who live longer and those who live shorter? And I think the power has been shown in several studies. And we have shown this and this is updated in March 2022. So it's still on the website. And you can see here that physical activity reduces all-cause mortality by 30%, cardiovascular by 35%, diabetes by 40%, hip fractures by 68%, dementia by 30%, and so on and so on. So this is really a pillar of health. It's really essential to keep you in good shape. So this is still on the website. I looked it up just recently, but the numbers are clear. So physical activity is one point, but physical fitness is another point. So physical fitness as the possibility to have a high oxygen consumption. And this was measured in 750,000 individuals with a follow-up time of 10 years. And they looked how was the physical fitness, so the VO2 max or VO2 peak, associated with a relative risk for mortality. And you can see here in all the ages from 30 to 49 up to the age of 80 to 95 years, that with increasing physical fitness, you have massive reduction of relative risk for mortality. And this column, the red column, which is equivalent roughly to a 50% relative reduction in mortality, was achievable at any age with the recommendation of the WHO of more than 150 minutes of moderate physical activity in both men and women. Yes, and so this is possible if you adhere to the recommendations which we are told from the WHO. But what is even more important that if we compare the relative risk living with comorbidities as shown in these subjects, in this 750,000 subjects, is even more remarkable. And I want to show it or explain it in that way. If we smoke and then have a 10-year follow-up, then we have a 1.5, 40% increase of relative risk to die. If we have diabetes, it's even lower. If we have AFib, at the same. Cancer, at the same. Cardiovascular disease, at the same. But if we have a low cardiorespiratory fitness, so lower than average, then we have an increase in relative risk increase in mortality of nearly 3 compared to 1.4, roughly 1.3, 1.4 if you have different diseases. So it's really important to improve your fitness. And if you want to say it let's say in a joke way, then you can say you can smoke forever, whatever, but you have to stay fit. That is really, really important. Have a look at your fitness. So I want to show you another example, which I think is remarkable. You know that there are several scores on the way, and the Framingham Heart Score, and I have here. There's a study based on the Euro score. And the Euro score is calculated on gender, age, systolic blood pressure, smoking status, total cholesterol, and HDL cholesterol. And in this study, which was done already in 2016, they added to the score the maximal exercise capacity measured according to the Bruce protocol. And they want to see how adding the maximal exercise capacity to the score modifies the risk to get the prediction model in order to survive, the survival model. And this has, if we then look at those who have a high score, and high score, but a low exercise capacity, then they have the highest probability, the highest hazard ratio to die, or the lowest to survive. And the hazard ratio to die, the relative risk, is 35% increased. But then if you have a high score, but a high exercise capacity, so a high cardiorespiratory fitness, then you are able to reduce your hazard ratio to 8. So it's remarkable what is the possibility if you are fit compared to those who are unfit, and if at the same risk according to the Euro score. And even more so, it's important to look at the net reclassification index. If you add this to the Euro score, you have the fitness to the Euro score, you have an overall improvement of 56.8%. That is tremendous compared to what is usually assumed as a good net reclassification index. A good net reclassification is at the average about 20%, 15 to 20%. But look at cardiorespiratory fitness, it's 56%. And that is really tremendous. We all should measure cardiorespiratory fitness. So why is cardiorespiratory fitness so important and so dramatic, increasing your prognosis, or if you put it into the calculation of risk? And I think it's so important because it's not only one parameter you assess, but you assess the function of the lung, in addition to the function of heart and the vessels and of the blood, and in addition to the muscular function. So the change, the so-called Wassermann gears, they all have to work together from for the transport of oxygen via the lung, via the heart and the blood and the proper vessels to the working musculature in order to produce energy. So if one element in this chain is not working properly, then you have a reduced cardiorespiratory fitness. So you have a parameter which clearly reflects in a very elegant and let's say, in a melting pot, your health. But I think in addition to this Wassermann gears, we should not only think of these gears, and more think of the motivation, and even should think of the autonomic nervous system. And we made a nice review where we could show that during COVID pandemic, there was a deletion of several, or a failure of several parts of the nervous system. We have damage on the endothelial function. We have direct damage on the afferent and and the ventilatory efficiency. We have a central hypersensitivity, and we feel fatigue even more easier than beforehand. And I think this is the fourth Wassermann gear, what we should think of, the autonomic and central nervous system. And even if we think of motivation, then we should at least think of this fourth Wassermann gear. So coming back to our study, we compared our data of the complete study, which is the red line over here, with data from other studies. And we had data from the Friend registry, which is probably the biggest registry in the world for cycling ergometry and VO2 peak, and for treadmill ergometry and VO2 peak. And we then compared complete data with the Friend data. And the Friend data, they are from the US. And you can see here in men and women, and if we look at absolute VO2 peak, and if we look at relative VO2 peak, then we can see a huge difference between our healthy subjects and the subjects of the Friend study, which are here at the end of several cohorts. And you can see that is really a big difference here in relative and absolute, and that is true for male and for female, and even stronger. And so we have to think, might this have a consequence for longevity? And I only want to, let's say, enhance or motivate thinking, and by comparing the life expectancy at birth and the development over the years, comparing the comparable countries, for countries in Europe with the United States. And you can see there's a dramatic difference in life expectancy at birth between the development between 1980 and 2022. And of course, this is the COVID pandemic over here, but still there is a huge difference between comparable countries. And might this be related to exercise capacity? That may be a question which I want to challenge. And I want to give you a little bit of information because it might have an association. Going to my last point, exercise and healthy longevity. So looking at the Generation 100 study, which is a really good and interesting study conducted in Norway. And you can see here that people made at the age of 70 to 77 years, they made exercise in 3 different ways. They had just control, then just normal standard recommendation, and then they made moderate continuous exercise, and they made high intensity interval training. And they looked at this time at the increase of peak oxygen uptake, which was only 0.7 milliliter per kilogram per minute in the HIT group, in the high intensity training group, compared to control and compared to moderate continuous training. But the result they observed was that if you look at cumulative death in percentage, that the lowest percentage was visible in the high intensity interval training group, which means that you exert your body, you get into sweating, and you make high intensity intervals in order to give a stimulus to your system. And has been shown that not only here in the outcome, that it works on the level of the outcome, which I think is most important, but it works as well in the level of the mitochondria. You can see that mitochondria works better, that they get bigger and they can fuse, so they are able to produce more ATP. And you know that the dysfunction of the aerobic capacity is mainly based on the dysfunction of the mitochondria. And this has been shown in this study and other studies as well. So we recently analyzed the data of the ENHANCE study, and we could show that exercise capacity, that intensity and not the, let's say, the volume of exercise is more important. So intensity of exercise, shown or reflected here by intensity gradient, that is a gradient which shows how high is the percentage of intensive exercise in your life compared to the volume. So you can accumulate, let's say, 10,000 steps, but these 10,000 steps may not be done in an intense way in order to have an effect on the body, in order to have an effect, a beneficial effect on your different organ systems. And if we look at this and at the intensity gradient in the ENHANCE data, then we can see that the reduction of the hazard ratio in order to die is reduced much stronger if you focus more on the intensity of exercise than if you focus more of volume of exercise. And we could add, in addition to that it is necessary to have at least 5 minutes in one bout of intense exercise in order to reduce your probability to die, then compared to have 10 times 30 seconds of moderate one, and you accumulate the same time of exercise, but only 10 times 30 seconds. So you have to have not only intense exercise, but you have to have a certain length of a bout in order to have a stimulus on your cardiovascular system. So 5 minutes, and in former times we said 10 minutes is necessary in order to have a good stimulus on your cardiovascular system in order to reduce your probability to die. So coming to my last few slides, the question is always, is it ever too late to start exercise? And I have this example of Robert Marchand, who participated in a study published in 2017, and he started in this study at the age of 104. And he made structured exercise between the age of 104 to 106. And the question was he able to improve his VO2 max, his maximum oxygen uptake? And the result was that he was able to improve it even at the age of 104 by 16%. And I think that's remarkable. So it's really never too late to improve your exercise capacity. It's never too late to improve your, let's say, one marker of healthy longevity and of healthy aging. So the physical function of the body. So how to prescribe this? How to prescribe exercise if we think it's really important? And I think it should be person-centered in an individualized way. And this has been shown by the Swedish FESC program, so physical exercise program. And if we look at this, it's evidence-based recommendation for physical activity. They get a written prescription on that, and they should exercise in a supporting environment, in a community-based network. So there should be, let's say, fitness studios and fitness or other fitness. The environment should be good for physical activity. There should be pedestrian areas in order to move. There should be cycling areas in order to move physically active to your work. And of course, you have to look at it, whether it works, the prescription, in a follow-up. So evidence-based prescription with a supporting environment and a follow-up, I think that is the real way to improve your healthy longevity. So finally, there is an example, and you probably have heard of Brian Johnson. And this Brian Johnson is questions whether we should all change our lifestyle according to Brian Johnson. Do we have to turn it to Brian Johnson at the end? Do we all have to make 1 hour of exercise training, 1/3 of endurance and stretching, and 1/3 of strength training without 1 hour? Should we take 100 pills per day? Should we have a strict calorie restriction and a vegan diet and other measures to improve your health? And he showed after 2 months of reducing already 10 kilograms, the heart is already not 45 years of age, but 37. And the lung capacity is like 18 years, and the gum is 70 years. So it's a really rejuvenation. So the question is, do we have to turn to Brian Johnson? I think impartial. It's okay to have everyday exercise training, maybe not that amount, but exercise training is clearly the pillar of these rejuvenation attempt. It's only an individual example, but I think in partial we could adhere to that. But what are the essential elements of the fountain of youth and these blue zones? And there is a lot of discussion about this, and but they have essential elements in there which is in a way reproducible. And of these elements, I think physical activity is one pillar. Everyday, lifelong physical activity, low, moderate intensity. Of course, we should now think about high intensity training, but integrated into the daily life. The other element, of course, is social connection. Yes, I think that is important. And of course, the outlook, the happiness of your life, the purpose of your life, the faith in you and your society is very important. And active participation in everyday life is important. But of course, and then with you, Alice, nutrition is important. And what you are talking about in your education, what you are teaching to people, I think that is really important. And all these things have to work together in order to have a healthy lifestyle, in order to have an optimal health, in order to have an optimal longevity. And with this, I want to close my presentation, and I'm open for your questions. Thank you very much.
Thank you very much. This was it was inspiring. I think you spoke to the interests of a lot of us because we are at an aging center, and very encouraging that there are things that we can do. So I would remind the audience to please add questions to the Q&A option on the bottom of your screen. I'll start off that I noticed, I think it was the complete trial, that dietary data was collected. Do you have any idea at all? Because you've got so many measures in terms of cardiorespiratory fitness, physical fitness, muscle, all that. Do you know anything about the diets of these people, or would you speculate?
Yes, the dietary assessment. I think I can now stop sharing, right? So that
Yes.
we have a yeah. So now we see each other a little bit more prominent. It's in that way that we assessed the dietary assessment was due to, let's say, a measure of time, only kind of, let's say, food frequency questionnaire, which we could do. But what we learned from this food frequency questionnaire, if we then calculate we calculate the Life Simple 7 on that basis, that it was really an essential element in that. And we calculate the Life Simple 7 based on the complete study, and looked at the association of the Life Simple 7 score with the pulse wave velocity, so with the arterial stiffness.
Yeah.
And it was a central element in a central parameter beside exercise capacity in order to improve arterial stiffness. And I think this is essential to know that it's not exercise capacity. Due to our analysis, exercise capacity was the most important element, but there are other elements in there, and nutrition was one element in there. So if we look at nutrition, the most important thing which we figured out in our food frequency was the amount, or not the amount, but the frequency of eating food and vegetables. That was the most important thing.
Mhm. Okay, thank you. And we do have one question that's come in. Can you say more about the value of exercise for those who already have one or more chronic conditions? This seems especially important in this country where we want to encourage people that it's never too late to improve their health and life expectancy. So
Yes.
I think the criteria, well, I'll let you address that.
I can make this very short, and I can say physical activity is really important for those who are multimorbid and for those who are healthy and only have one disease. But the most important thing, and I'm looking at morbid obese patients as well in our we make consultations for them at the university hospital. And we see that you have to look into the way how to counsel them in order to get more active. And of course, in the beginning, every step counts. That is crystal clear. But then you have to get more and more out of it. And what we see that it is most important to really to guide them in order to increase their physical activity and not to get pain, for example, in their joints, to get pain in the knee, to get pain in the Achilles tendon, and so on. So you have to make it in a structured way in order to get the whole body improved, not only the muscle, not only the metabolism, but all as well the so-called passive organ, so the cartilage, the tendons of the body. So to get the whole body and the motivation into one system in order to get them to more and more into lifelong physical activity. That is really a challenge. That is the big challenge, not the knowledge, how much they should achieve at the end, but the way to go to that final goal. That
So
is
that's
really important. And then, of course, you have to know, just to add this,
yes,
you
please.
have to know what are the contraindications and in which way, for example, you have to treat high blood pressure in that way, and what kind of exercise is beneficial for that, and what kind of exercise is beneficial, for example, for diabetes type 2. So you have to differ, you have to really to prescribe exercise in different ways.
Thank you. And I think that really, your example of that gentleman that was 103 or 104 when he started really speaks to it's never too late. So another question is, what are your thoughts about the efforts of the longevity biotech industry to find pills that will increase health span or lifespan when we already know a lot about how to maximize lifespan through exercise and diet, which you've
Yeah.
explained. And that's something I was going to ask you about with Brian Johnson and that
Mm.
huge number of pills that he was taking.
Yes. Well, there you call a little bit about or you address the physical activity mimetics. So the drugs who may mimic physical activity. And of course, there are many companies are working on that. We have, in Basel, we have Novartis, we have Roche. They are working on that. They are very much interested now in the function of exercise. And I always tell them, if you think of the function of exercise, then you think of a whole system. It's a system approach. It's an approach which addresses multiple points in your system, which stimulates multiple ways of energy production and multiple hormonal ways. And at the moment, there is really no drug which is able to do that. And even if you think of hormones like testosterone, yeah, because the testosterone doping is not only done in athletic sports, but it's done in fitness studios as well, in fitness clubs. And people do not know that 1/3 get addicted to that. They really do not acknowledge this harm which should occur. But even if you take testosterone, it's necessary to make exercise in order to get the best out of it. So to get your muscle growth, in order to improve your capacity. So I do not know any drug which is really able to mimic the potential of exercise in itself. And there's a recent big debate about this called LAKE. So LAKE. So a drug which is it's a precursor of lactate and of ketone
Okay.
bodies, butyrate. And of course, if you have these lactate for a certain time in your body and you have butyrate in your body, lactate reflects aerobic exercise at a longer duration, and butyrate reflects the increase in fat metabolism induced by exercise, then you have only these two compounds in your body, but you do not have the increase of blood flow during that time, which tears at your endothelium, which makes your muscle, the smooth muscle of your vascular system, smooth and working better. And you do not have the impact on the bone, and you have the impact on the brain. You do not have all these other things which is associated with exercise, with enhanced exercise, agility aspects, dancing, which is very good for the body. All these kinds you can only mimic very few points in the system, but you are not able to improve the function of the whole system.
And then we see a parallel with that when we thought the easy thing to do would be to prevent cardiovascular disease, lower risk with vitamin E, with vitamin D, with beta
Yes.
carotene, and with folate, even though there's biological plausibility, this same thing. So another question has come in. There are lots of scientists and medical professionals advocating for muscle-centric medicine, as more muscle often results in many health and metabolic benefits. However, this type of training usually involves a focus on aerobic exercise. Can you comment on the discrepancy in benefits? That is one better than the other in terms of longevity, or does it depend on your goals?
Yes, it's in that way that let's say, muscle strengthening, I think it's essential, even if you get older. If you get older, it's getting more in the forefront because people who want to exercise, they first have to improve their muscle strength, then they can improve their aerobic capacity better. Because a good muscle is a prerequisite for improving aerobic exercise capacity. So it's not this way or the other way, but it's a combination. But if you look at the data, the epidemiological data, and you look, for example, at jogging compared to walking. Jogging means that you fly in the air and then you bump on the ground. And this occurs with every step. And at every step, you make an impact on the muscle and on the whole body. And this impact on the muscle with a certain intensity increases all these inflammatory pathways, but not in that way as a devil, but as an angel. And we do not really know why this happens at the moment, but it seems to be essential to stimulate or to challenge the muscle in this way in order to get these myokines out of the muscle, which then works in the whole body. And so you have certain types of exercise, like in muscle strengthening, which may produce this kind of, for example, inflammatory or myokines, of course, as well. But it has shown that jogging for most of the people is the most effective way in order to produce this myokines for the body. So I think that is not this or that, but it should be a combination. And at best, it should be in that way that you have it in this kind of exercise as it is done by jogging. Does it answer your question in a way?
It likely answers the question of the person who asked. Okay, and then one last question that's come in. In the Wagner study, the comparison is based on VO2 max at 0. Would it be better or more useful to compare it to VO2 max needed for minimal activity? Is that question clear for you?
No, not completely. I could make an assumption about that.
Okay, you might as well. And then if the person who asked wants to clarify, type it in. No, I think, would you like to speculate?
Yeah, I would like, maybe it's in that way. I think it's, if we only think of the minimum of exercise we need for exercise capacity, we need for our daily living, then we are at the end, that's a kind of, let's say, we do not challenge the system in order to improve, but we have to challenge the system in order to supercompensate. And only if we challenge the system in that way, that we go over the capacity which is needed for the minimum, then we can induce an adaptation. Without this challenge, we do not induce an adaptation. And we have to induce it, not in order in the forefront to get a higher fitness, but to induce all these pathways in order, which are necessary to have an impact on the hallmarks of aging. Because you only can, let's say, reduce the shortening of the telomere if you have a certain amount of exercise and a certain intensity. It's only possible with this if you go over the thresholds and if you're not staying at the minimum. Of course, if you are doing really nothing, then every step counts. Yeah, but that is not, at least not enough for Swiss people. Swiss people have, at average, they have already 6,000 to 8,000 steps per day. At average, yeah, even those people who are inactive. And you know that inactivity is defined as lower than 5,000 steps per day. Yes, but you should go really more and if higher. And if you are a Swiss guy, then of course we have to make exercise in order to improve your exercise capacity. Maybe those people who are only driving in a car, if they get out of the car, then every step counts. But that is not enough.
Okay, well, I think we've run out of time. I thank you tremendously. This was an extraordinary talk that really resonated with your audience. So thank you very much appreciated.
Yes, thank you. Thank you for the invitation. It was a pleasure to give this talk.
Yeah.